So I don't think we need this Calip's class, so we're going to next page. So in next page we can see there is cardiovascular disease. It's investigations. So this cardiovascular disease and investigation of that coronary artery syndrome, acute coronary syndrome. Investigation of acute coronary syndrome electrocardiography is very important in case of any heart diseases. The ECG is central to confirming the diagnosis, but may be difficult to interpret if there is bundle branch block or previous myocardial infarction. So ECGs play a very important role in determining the risk factor for the acute coronary for the myocardial infarction. However, there might be a diagnosis might be not that well interpreted if there's any bundle branch block or previous case of myocardial infarctions. The initial electrocardiogram may be normal or not non-diagnostic in 1/3 of the cases. The initial electrocardiogram may be normal or non-diagnostic in 1/3 of cases. However, repeated ECGs are important, especially where the diagnosis is uncertain or the patient has recurrent persistent symptoms. The earliest electrocardiogram change is usually ST segment deviation, with a proximal occlusion of a major coronary artery. ST segment elevations is seen initially with a later diminution in the size of the R wave, diminution of the size of the R wave, and that transmural and in the transmural fuel thickness infarction. Okay, I need to get this. The earliest electrocardiogram change is ST segment deviation with proximal occlusion of a major artery. So if there is occlusion of an artery in proximal part with proximal occlusion of major coronary artery, ST elevation segment elevation is seen. ST segment elevation is seen initially, with later diminution in the size of R wave. Initially, there is ST segment elevation in case of proximal occlusion of a major artery. However, later on there is diminution in the size of R wave. The R wave is diminuted, and in transmural infarction, development of Q wave. And in case of transmural infarction, the development of Q wave is diminuted as well. Q wave is diminuted as well in case of transmural thickness. Okay, subsequently the T wave becomes inverted because of the change in ventricular. Subsequently the T wave becomes inverted. Okay, because of a change in ventricular repolarization. T wave might become inverted because when change in ventricular repolarization. So for this we need to understand the action potential. So when we need to understand this electrocardiogram. When there is change in ventricular repolarization, the T wave get inverted. This change persists after ST segment has returned to the normal. This sequential feature are sufficiently reliable for approximate age of the infarct to be deduced. These sequence features are sufficiently reliable for the approximate age of the infarct to be deduced. In non-ST segment elevation, acute coronary syndromes, there is partial occlusion of major vessels. In non-ST segment elevation acute coronary syndrome, there is partial occlusion of a major vessel or complete occlusion of a minor vessel, causing unstable angina. In non-ST segment elevation acute coronary syndrome, there is partial occlusion of a major vessel or complete occlusion of minor vessels, causing unstable angina or partial thickness myocardial infarction. This is usually associated with ST segment depression and T wave changes. In non-ST segment elevation acute coronary syndromes, ST segment elevation acute coronary syndrome, there is partial occlusion of major vessels or complete occlusion. Generally, in acute coronary syndrome, there is ST segment elevation, but in some cases there might not be a ST segment elevation. In that particular case, there might be a partial occlusion of a major vessels or complete occlusion of a minor vessels, causing unstable angina or partial thickness myocardial infarction. This is usually associated with ST segment depression. In this case, there might be a ST segment depression. In what case there might be ST segment depression? In case of partial occlusion of a major vessel or complete occlusion of a smaller vessels. And T wave changes occurs in that particular case as well. So So for that, so for angina to get to happen, there is a T wave depression and ST segment uh, T wave involved in ST segment depression. The similar phenomenon is achieved in case of uh, in case of uh, in case of acute coronary syndrome. Acute coronary syndrome, if it is not that severe. For not severe meaning that the major vessel is partially obstructed and the minor vessel is completely obstructed. And T-wave change. In presence of infarction, this may be accompanied by some loss of R wave in the absence of Q waves. The electrical ECG changes are based in the leads that face the ischemic. Changes are based in the leads that face the ischemic or infarcted areas. Okay, there is not a particular lead that would show the ischemia. However, the lead that is near to the infarcted area would certainly show the change. When there has been anteroseptal infarction, abnormalities are found in one or more leads from B1 to B4, while anterolateral infarction produces changes from B2 to okay. When there have been anteroseptal infarction, abnormalities are found in one or more leads. And whatever an anteroseptal infarction. So this is heart, and septa is actually a space in between heart, and septa could be in the anterior part and the posterior part. So if there is infarction in the anterior part of the septal lesion, there is abnormality which is found in V1 and V2, V1 and V1 to V4. It includes V2 and V3 as well. While anterolateral infarction produces the changes from V4 to V6. Okay, if there is any changes in anterolateral, this is heart, and around this part, if there is an infarction, then the change is shown in the leads such as V4 and to V6. In AVL and in lead inferior infarction is best shown in details, and in lead infection is best shown in leads 2, 3, and AVF at the same time leads. Okay, and inferior infarction is inferior. If the infarction occurs in the inferior part of the heart, then it is well stored in the lead 2, 3, and AVF lead, while at the same time lead 1 and AVL and the 1 AVL, AVF. What? AVF means which is present in the left foot, and AVL means which is present in the left hand. And the anterior and at the same time leads 1 and AVL and the anterior chest leads may show reciprocal change of ST depression. Infarction of posterior wall of the LV does not cause ST segment. Infarction of posterior wall of the LV does not cause ST elevation. If there is infarction in the posterior part, it won't cause the infarction of the posterior part. Then there won't be LV doesn't cause ST elevation. It won't cause the ST elevation or Q wave in standard leads. Or LV does not cause ST elevation or Q wave in the standard lead, but can diagnose by presence of reciprocal changes ST depression and tall R waves. ST depression and tall R wave in lead V1 to V4. So reading electrocardiogram is very important. It helps to diagnose whether the person is having myocardial infarction in anterior portion of the heart, or whether he is having an infarction at anterolateral portion of the heart, or in the inferior part of the heart, or in the posterior part of the heart. If there is infarction at the posterior part of the heart, then there is no ST elevation or Q wave is interpreted. However, it could be diagnosed by reciprocal change, diagnosed by presence of reciprocal change of ST segment, reciprocal changes of ST depression and tall R waves in the lead V1 to V4. So it is seen in V1 to V4 as well. So anteroseptal infarction is found in case of lead V1 to V4. And anterolateral is found in V2 to V6, V4 to V6, and the inferior part is actually found in lead 2, 3, and lead 2 3 inferior part of the infarction or infarction is found in lead 2 3 and APF, and at the same time it is also this was the reciprocal change of ST depression, and at the same time lead 1 and lead ABL shows the reciprocal changes of ST depression. So I need to watch this figures for the separate. Okay, now let's see the figure. So this is, I think this is a normal ECG. Yes, normal ECG complex, and this one right here has some abnormalities. What abnormality? This looks like a normal action potential of excite cells. So there is this is PQRST. The R and S complex is elevated, and there's no T complex. I think in this case, let's see. Acute ST elevation. There's absolutely is an ST elevation. The current of injury. Okay. The progress loss of R wave. There is loss of R wave. So this will be PQR. There is loss of R wave developing Q wave resolution of the. Okay, let's read it properly. Progressive loss of R wave developing Q wave resolution of the ST elevation and terminal T wave inversion. This T wave inversion in this case is there. PQR. Yes, there is inversion of T wave, and there is loss of the R wave. This is the serial evolution of issues in transmural MI. Okay, at first it is normal, then there might be elevation of ST segment, then there might be change, there might be loss of a height of a R wave. So just let's compare these two figures. Previously the R wave was at top, yes, at top, and in this figure the R wave is little below than the previous value, and similarly the T wave is inverted in this case. Okay, the T wave is inverted. Let's come to the point T. Deep Q wave and T wave inversion. Deep Q wave and T wave inversion. Okay, Q wave and T wave. This is a Q wave and this is T wave. Inversion simply means that it is depressed. Okay, so Q wave is initially right here in this normal line. However, in this case the Q wave is very below. So there is Q wave inversion and T wave inversion as well. And in this figure number E, there's all or established impact pattern. The Q wave tends to persist, but Q wave tends to persist. Yes, Q wave is persisting, but the T wave changes becomes less marked. So T wave was initially highly marked, but here in this figure it just becomes less marked. Stage C within 4 hours, stage D within the days, and stage E after several weeks or months. This would be compared with the tubal lead ECG figure. This will be compared with tubal lead electrocardiogram ECG in figure what? Figure 18.72 to 80.7. Okay, let's watch what is in 18.72. This was about transmural elevation, transmural myocardial infarction. This was about transmural myocardial infarction. Transmural means what? Sorry. So number 1. Okay, these are here we have been given the different leads. Lead 1, lead AVR, that is present in right hand. This is in this lead is kept in the left hand. This is lead 2, this is lead 3, and this is V1, V4, V2, that's 5, V3, V6, and we'll be talking about it. Recent anterior non-ST elevation, subendocardial MI. So this is a case of subendocardial MI in which there is no ST elevation. This is demonstrates deep symmetrical T wave inversion. There is T wave inversion, but in which okay, the ECG demonstrates deep symmetrical T wave inversion together with a reduction in the height of R wave in the leads V1, V2, V3, and V4. V1, V2, V1, V2, V1, V1, V2, V3, and V4. This T wave inversion. Yes, there is T wave inversion. So normally there is PQR. This is T wave, but in this case there is inversion. Yes, even in this case there is inversion. Even in this case there is inversion, and in this case there is inversion. However, there is no inversion in other figures. So this is in case of subendocardial myocardial infarction. There's no ST elevation in any of the figure. However, there was ST elevation in case of a transmural myocardial infarction that we just observed in this previous figure. There's no elevation. Okay, let's move on to the next figure. This is acute transmural anterior myocardial infarction. Acute. Okay, this is acute transmural throughout the heart, anterior myocardial. So anterior myocardial infarction. So we just previously studied that anterior myocardial infarction is seen in case of lead V1 to V4. So let's say this okay, acute transmural anterior myocardial. This EC was recorded from a patient who had developed severe chest pain 6 hours earlier. Okay, there was ST elevation in leads 1, AVL, V2, V3, V4, V5, and V6 up to V6. And there are Q waves in leads V3 and V4 and V5. There are Q waves in lead V3, V4, and V5. Anterior infarct with prominent changes in leads V2, V3, and V4 are sometimes called as anteroseptal infarct, as opposed to anterolateral infarct, in which ECG changes are predominantly found in V4, V5, and V6. Okay, we need to observe there is a so we can identify that there is ST elevation in lead 1. If there's ST elevation in lead 1, is there an ST elevation in case of lead 1? There might be an ST elevation right here. Yes, there PQRS. There is ST elevation in this case. Lead 1. Okay, there is ST elevation in this V2. There is ST elevation in case of V3. ST elevation here. AVL. Let's see the AVL. Yes, there is ST elevation in there as well. Okay, so this is case of acute transmural anterior myocardial infarction, and there is ST elevations, which give a diagnosis of a heart failure. So ECG is one of the most important factor that determines if the person is suffering from acute coronary syndrome or not. However, there is other factor that plays a very important role as well, and it is a plasma cardiac biomarkers. In unstable angina, there is no detectable rise in cardiac biomarkers or enzymes, and the initial diagnosis is made from clinical history of ECG only. Okay. In contrast, myocardial infarction cause a rise in plasma concentration of enzyme and protein that are normally concentrated within the cardiac cell. Okay, these biochemical markers are creatine kinase, more sensitive and cardiospecific isoform of this enzyme is creatine kinase MB, and the cardiospecific protein troponin T and I. Admission and seed. Okay, so I'll be explaining up to this point. So heart has different cells. These different cells have specific protein stored within them. And whenever these cells is damaged, this particular protein is excreted in case of excreted in it just goes to the bloodstream, and from that we could demonstrate if the person is having myocardial infarction or not. So if this cell get lyased, the protein from here just will come and will enter to the bloodstream. Suppose this is creatine kinase, this is troponin. They will enter into the bloodstream, and by biochemical test we can demonstrate if the patient is having myocardial infarction or not. Addition and serial estimation are helpful because it is change in plasma concentration of these markers that confirms the diagnosis of myocardial infarction. Admission and serial estimation are helpful because it is change in plasma concentration of this biomarker that confirms the diagnosis of myocardial infarction. Okay. So when the patient comes with the myocardial infarction, and just was by looking at the electrocardiogram, we could not just give them a diagnosis. So we must admit them to check out the biochemical marker. Since biochemical markers will take a time to get result of biochemical, so it generally takes a lot of time to takes I think a few hours to get a report of this cardiac biomarker. So the patient should be admitted. Creatine kinase start to rise at 4 to 6 hours, peaks at about 12 hours and falls to normal within 48 to 72 hours. Creatine kinase is also present in skeletal muscle, and modest rise in creatine kinase may sometimes be due to intramuscular injection. Vigorous physical exercise, particularly in older people. Uh, so CK is also present at no skeletal. So CK is actually present in the skeletal muscle as well. However, the CKMB is exclusive to the heart. May sometimes be due to the intramuscular injection, vigorous physical exercise, particularly in the older. So these are things that we need to understand. If the patient have a high CK value, it might be due to these factors. The factors are physical exercise, particularly in the older people, or fall or defibrillation. Okay, or fall. Defibrillation causes significant release of creatine kinase, but not CKMB or troponins. The most sensitive biomarkers of myocardial cells damage are the cardiac troponin T and I, which are released within the 4 to 6 hours and remains level up to the 2 weeks. Okay, this is very important note. It remains up to the 2 weeks. Okay, CKMB is important. However, it is not seen in case of defibrillation. However, there is increasing amount of creatine kinase, but this particular creatine kinase is also found in skeletal muscle, so very difficult to understand. Okay, so very difficult to demonstrate. The most sensitive markers of myocardial impact damage troponin I and troponin troponin T and troponin I, and it is released within the 4 to 6 hours, and it will remain in the bloodstream up to the 2 weeks. So we could perform the test up to the 2 weeks to demonstrate if the patient is having coronary syndrome or not. So this is a figure in which we can demonstrate these various cardiac various biochemical markers for various biochemical markers. So creatine kinase, creatine kinase. This one is creatine kinase, and this is troponin 1 the first to rise, followed by aspartate aminotransferase. This is aspartate aminotransferase, and then lactate dehydrogenase. Lactate dehydrogenase at this point. In patient treated with a diffusion therapy, a rapid rise in plasma creatine kinase occurs due to the washout effect. Let's learn about this figure just a little bit. This is troponin. Change in plasma cardiac bioconstance, creatine CK and troponin T and I are the phosphorylase. So creatine kinase CK and troponin 1 is phosphorylase. However, this creatine kinase should be neglected because it can be high in case of skeletal damage, but troponin 9 is specific to the cardiac damage, so it should be noted. So creatine kinase and troponin 1 is phosphorylase followed by aspartate aminotransferase. So aspartate transferase then rises, and then lactate dehydrogenase rises. In patient treated with the reperfusion therapy, a rapid rise in plasma creatine kinase occurs due to the washout effect. Okay, other blood tests, there might be other blood tests as well. Other blood tests could be performed. What are the other tests? Leukocytosis is usually reaching a peak on the first day. Leukocyte increase in case of myocardial infarction in first day, and ESR will increase obviously, and C-reactive protein are also elevated. Okay, other blood tests could be performed, and other blood tests might include leukocyte count and erythrocyte sedimentation rate and C-reactive proteins, which are generally increased in the normal. So let's talk about chest X-rays. There may be okay. In what can we find in chest X-ray in case of acute coronary syndrome? They may demonstrate a pulmonary edema that is not evident on clinical examination. Okay, there might be a condition of pulmonary edema in case of acute pulmonary syndrome, however, which is not observable to the clinical examination. So this might be rare. The heart size is often normal, but there may be cardiomegaly due to the pre-existing myocardial damage. Okay, we can observe the shadow of the heart in case of chest X-ray, and we can observe there if there is presence of pulmonary edema or not, which are not seen in case of physical examination. Figure 18.25. This was 18.6. I am not ready to go out there. I just can't. This echocardiography. This is useful for assessing ventricular function and for checking important complications such as mural thrombosis, cardiac rupture, ventricular septal defect, mitral regurgitation, and pericardial effusion. Immediate management. Okay, immediate management are the first to allow management of a cardiac Okay, acute coronary syndrome, this is very important. If the patient should be admitted urgently to the hospital, obviously, because there is significant risk of death and recurrent myocardial ischemia during the early unstable phase. Okay, there might be recurrent myocardial ischemia might occur often during the early unstable phase, and approximate medical therapy can reduce the incidence of these by 60%. The essential of the immediate in hospital management acute coronary syndrome are shown in figure this. Okay, this is an immediate hospital management. I would be going out there. Later on, but patient usually managed in a dedicated cardiac unit whether necessary expertise monitoring and the resuscitation process can be concentrated. If there is no complication, the patient can be mobilized from the second day and discharged after 3 to 5 days. Analgesia. Okay, analgesia can be given in this protocol. Adequate analgesia. Do you want to go there? Let's go. 18.13. Okay. Okay, I've been this here. So the patient comes with how to manage the patient of acute coronary syndrome. It becomes initially summary treatment acute coronary syndrome. So at first there should be ECG, immediate clinical assessment, ECG and troponin. This is cardiac biomarker test should be performed, and then oxygen plus cardiac rhythm monitoring should be performed. Aspirin should be given 300 mg per oral, and ticagrelor 180 mg per oral should be given. Metoprolol, this is beta 2 agonists, I think. Metoprolol should be given. Transfer of specialist cardiology unit should be done. Then ST segment elevation. If there is any ST segment elevation, then presenting less than 12 hours from symptoms onset. So if he is presented within the less than 12 hours of symptoms, which is generally true, then this issue should be undergo the reperfusion therapy and primary PCI. Okay, and then this will go under the primary percutaneous intervention. Okay, within the 120 minute, and if they might be ineligible for this process. So if they could not do this, then eligible for they should be checked if they are eligible for thrombolysis or not. If yes, then they should be given thrombolysis IV or fondaparinux or low molecular weight heparin 4. Or if they are not eligible for this as well, then they should be again for the primary percutaneous intervention available. Okay, and then there should be, so then they will go to the GP2B 3B receptor antagonist, emergency percutaneous intervention plus emergency percutaneous intervention. Okay, then ST segment. If there is no ST segment elevation, what should be done? Fondaparinux or low molecular weight heparin should be given. Subcutaneous consider nitrate intravenous infusions of heparin is subcutaneous, and low molecular weight heparin subcutaneous. Fondaparinux or low molecular weight heparin subcutaneous is given, and nitrate intravenous infusion should be given. Why nitrate intravenous infusion? Because it helps in dilatation, I think. Calculate the GRACE score. So there should be there is something called GRACE score. GRACE score in hospital. Okay. Low risk less than 1%, medium risk 1 to 9%, high risk 9%, medium to high risk or not. If he is medium risk, then they should undergo the medium to high risk. If they fall under this category, yes, then early in hospital coronary angiography positive consider GP receptor antagonist should be infused. And if not, then recurrent symptoms. If we should observe whether he or she have recurrent symptoms or not. If yes, then he should be perform that particular thing anyway. Okay, failed reperfusion. So thromboplastin and fondaparin low molecular heparin is given. If the reperfusion is failed, then he or she should again go for GP2B3A receptor antagonist along with the presence of emergency percutaneous intervention and maintain, and then ultimately they should be under the maintenance in the hospital. Okay. So we're up to the analgesics here. Adequate analgesics is essentially not only relieve distress but also lower the adrenergic drive and thereby reduce the vascular resistance, blood pressure, infarct size, and susceptible to the ventricular arrhythmias. Intravenous opiates. Okay, intravenous opiates initially morphine sulfate 5 to 10 mg or diamorphine 25 to 5 mg should be given, and along with the antiemetics. Initially metoclopramide, okay, should be administered and treated and titrated by giving repeated small adequates until the patient is comfortable. Intramuscular injections should be avoided because the clinical effect may be delayed by poor skeletal muscle perfusion. Painful hematoma may form following the thrombolytic and antithrombocytic properties, and the thrombotic therapy should be given to them. What does it include? I need to know this term, deperfusion therapy. I'll be dealing with it later. So the antithrombotic therapy, antiplatelet therapy. At first, this should be given antiplatelet therapy in patients with the acute coronary syndrome. Oral administration of a 75 to 325 mg aspirin daily improves the survival within 25% relative risk reduction in the mortality. The first tablet 300 mg should be given orally within the first 12 hours, and therapy should be continued indefinitely if there are no side effects. In combination with aspirin, the early within 12 hours use of clopidogrel. That is clopidogrel how much? 600 mg. Okay, 600 mg followed by 150 mg daily for 1 week, and 75 mg thereafter. Okay. First, clopidogrel should be given 600 mg at first dose. Then the 75 mg should be okay. Then 150 mg should be given for 1 week, and then 75 mg should be given the next days. Okay, confers a further reduction in ischemia events in patient with an acute coronary syndrome with or without ST segment elevation. Ticagrelor followed by twice daily is more effective than clopidogrel in reducing vascular death, myocardial infarction or stroke, and all cause of death without affecting overall major bleeding risk. Okay, I didn't get anything. I need to study it again. Read it again. We're up to here. Conflict for the reduction of ischemic events in patients with the acute coronary syndrome with or without ST segment elevation. TICA with or without ST segment elevation. In case of the acute coronary syndrome, okay, with or without ST segment elevation, ticagrelor 180 mg followed by 90 mg twice daily is more effective than clopidogrel in reducing vascular death. If the patient is without the ST segment elevation, then ticagrelor is given 180 mg followed by 90 mg twice daily is more effective than the clopidogrel in reducing vascular death. Myocardial infarction or stroke, and all cases of death without affecting the oral major bleeding. So ticagrelor is important as well. Ticagrelor is important and can be given in place of clopidogrel. Yeah, it has antiplatelet effect. Glycoprotein 2B3A receptor antagonists such as tirofiban and amoxicillin block the final component pathway of platelet aggregation and are potential inhibitor of platelet-rich thrombus formation. They are form of particular benefit in patients with acute coronary syndromes which undergoes they are of particular benefit in patients with acute coronary syndrome which undergoes percutaneous intervention. Those with a recurrent ischemia and those of particular high risk, such as patients with diabetes mellitus and elevated thrombin concentration. This will be given glycoprotein 2B3A receptor inhibitors, such as amoxicap. Amoxicap is famous. Tirofiban, I haven't heard about tirofiban, but amoxicap is famous. But the final component of the platelet aggregation and put induction platelet is in thrombus, and they are other particular benefit in patients with the acute coronary syndromes undergo percutaneous intervention. Those with a recurrent ischemia and those particular high risk, such as patients with diabetes mellitus or elevation thrombin intervention. Okay. Five-minute break. So anticoagulant. Anticoagulant reduces the risk of thromboembolic complication and prevent the infection in the absence of reperfusion therapy. Okay, thromboembolic complications prevent the formation of thrombus and embolism from that. And it also prevents the reinfection in the absence of reperfusion. In the absence of reperfusion therapy. So basically, anticoagulant act as buying time for reperfusion therapy, or after successful thrombolysis, anticoagulant can be or after successful thrombolysis, anticoagulation can be achieved using anticoagulant can okay and anticoagulation can be achieved using unfractionated heparin. Okay, heparin, there are various forms of heparin. One of the forms on unfractionated heparin, fractionated fractioned fractioned heparin, or pentasaccharides. So low molecular weight heparin, I think it is unfractionated heparin. High molecular weight heparin is unfractionated heparin. When the heparin is fractionated, it ultimately it results in the formation of a low molecular weight heparin. Or pentasaccharide is used instead of heparin as well. Pentasaccharide is also anticoagulant. So basically, what does anticoagulant do? Anticoagulant just buys the time for the perfusion therapy, and reduces the risk of thromboembolism as well. Okay, comparative clinical trials suggest that pentasaccharides. Okay, these pentasaccharides subcutaneously fundaparin of 2.5 milliliter have the best safety and efficacy profile with low molecular weight heparin subcutaneously, being a reasonable alternative. So the most suitable is pentasaccharide, and the name is given as a fundaparinox 2.5 mg twice daily. However, its alternative could be low molecular weight heparin, which should be given twice a day, 1 mg twice. Sorry, its alternative is low molecular weight heparin for Peter's universe. Being to reasonable, anticoagulation should be continued for 8 days or until discharge of hospital or coronary revascularization. A period of treatment with warfarin should be considered if there is persistent atrial fibrillation or evidence of extensive anterior infection, or if echocardiography shows mobile middle thrombus, because these patients are not increased risk of systemic thromboembolism. A period of treatment with warfarin should be considered if there is persistent atrial fibrillation or evidence of extensive anterior infection, or if echocardiography shows mobile mural thrombosis, because the patients are at increased risk of systemic thromboembolism. Okay, so what even anti-anginal therapy? Sublingual bisal. So there might be anti-anginal therapy, and what should be done in case of anti-anginal therapy? Okay, as suggested before, sublingual glycerol should be given, and the content is like on the amount is 300 to 500 microgram is available for first aid measure in unstable angina or threatened infection, and intravenous nitrate glycerol 0.6 to 1.2 milligram per hour, or isorbide dinitrate 1.1 to 2 milligram per hour are useful for treatment of left ventricular failure and the relief of recurrent or persistent ischemic pain. Okay, intravenous beta blockers, atenolol, metoprolol. Okay, intravenous beta blockers, example atenolol or metoprolol. Okay, beta blocker atenolol, metoprolol relieve the pain, reduces erythemas, and improve the short-term mortality in the patient who's present with 12 hours of onset of symptoms. However, this should be avoided if the heart failure. If there is heart failure, in which there is especially pulmonary edema. Okay, because it consists of because beta blockers could cause the spasm of the bronchospasm. It might cause the bronchospasm that might be fatal in case of heart failure, because in case of heart failure there is already a pulmonary edema with additional pulmonary edema plus bronchospasm could be fatal to the patient. And hypotension condition and bradycardia. Okay, dihydropyridine calcium channel agonist, example nifedipine and amlodipine. Amlodipine can be added to the beta blocker if there is persistent chest discomfort but may cause tachycardia. if used alone. Because of their rate limiting action, the verapamil and diltiazem are calcium channel and agonist of choice of beta blocker. Agonist of choice if a beta blocker is contraindicated. Okay. So let's talk about the reperfusion therapy. What is reperfusion therapy? Okay, let's revise this. So glycerol trinitrate is given. However, glycerol trinitrate is given. It could be given sublingually 300 to 500 milligram, or it could be given 310. It can be given intravenously 0.6 to 1.2 milligram per hour, or acerbate dinitrate could be given 1.2 milligram per hour in case of intravenous route. And these are useful in treatment of left ventricular failure. Okay, and the relief of recurrent persistent ischemic pain, and they also help in relieving the ischemic pain. So intravenous beta blocker could be given, such as atenolol and metoprolol could be given. However, however, the patient should be considered consider if he or she is heart failure or not, because in this case this is contraindicated. These drugs are contraindicated. These drugs are also contraindicated in case of hypertension and bradycardia. And the hydroperoxychannel blockers like nifedipine and amlodipine can be added to the beta blocker. Beta can be given with the difedipine and amlodipine if there is a persistent chest echo, but may cause tachycardia if used alone. Okay, it might cause tachycardia if they are used alone. If used alone, because of their limiting action, verapamil and diltiazem are calcium channel antagonists of choice. The alpha beta blocker is contraindicated. Okay. So verapamil and diltiazem should be given if the beta blocker in this case is contraindicated. Now beta blocker is contraindicated in case of asthma because there is a bronchospasm. It might cause to the bronchospasm, so calcium alone should be given in that particular case. So let's talk about the reperfusion of theory. Non-ST segment elevation acute coronary syndrome. Okay, immediate emergency reperfusion therapy has no demonstrable benefit in patients with non-ST segment elevation myocardial infarction. Immediate emergency reperfusion therapy has no demonstrable benefit in case in patient with non-ST segment elevation myocardial infarction, and thrombolytic therapy may be harmful. Selected medium to high risk patients do benefit from in-hospital coronary angiography and coronary revascularization, but this doesn't need to make this space. Okay, I just need to. Yes. Let's study this first. Intravenous glycoprotein 2B and 3A inhibitors in acute coronary syndromes. In patients with acute coronary syndromes, antiplatelet treatment with IV glyco inhibitors reduce the combined endpoint of death. Okay, most benefit is seen in case of context of percutaneous coronary intervention, but there is no convincing evidence of benefit in patients who are treated with revascularization. Let's study this as well. Anticoagulation in acute coronary syndrome. Aspirin plus low molecular weight heparin is most effective than the aspirin alone in reducing the combined endpoint of the death. In case of myocardial infarction, myocardial infarction, refractory angina, and urgent need for revascularization. In comparison to the low molecular weight heparin, the pentasaccharides fondaparinix is associated with the lower bleeding rates and even overall survival. But can fondaparinix is given with heparin? No, it's given with heparin. No, given with aspirin, this should be considered. I think it could be given with fondaparinix, which is pentasaccharides and antiplatelet, anticoagulating drug, anticoagulating fondaparinix. Reperfusion therapy. Immediate emergency reperfusion therapy has no demonstrable benefit in patients with immediate emergency reperfusion therapy has no demonstrable benefit, so it should not be done immediately in patients with non-ST segment elevation, specifically in patients with non-ST segment elevation. If the patient is not present, if the patient with the myocardial infarction is not present with the ST segment elevation, then he or she should not be given non-ST segment elevation. Why I'll be talking about later. Selected medium to high risk patients do benefit from the in hospital coronary angiography and coronary revascularization, but this does not need to take place in first 12 hours. Benefit from the hospital coronary angiography and coronary revascularization, but this doesn't need to take place in the first 12 hours. Incidence: coronary artery disease increases in an effect Incidence, comorbid conditions, calcific aortic stenosis or typical presentation, angioplasty. Okay, angina in old age, incidence, coronary artery. Okay, this is a separate topic for the angina in old age. Okay, incidence coronary artery disease increases in and affect women almost as often as men. Okay, comorbid condition, anemia and thyroid disease are common and may worsen angina. Okay, in case of old people. Calcific aortic stenosis is common and should be sought in old people. If old people come with a symptom of angina, then he or she should be looked further. Calcific aortic stenosis, because these are very common in case of old people. And atypical presentations. Typical presentation, when myocardial ischemia occurs as little changes in myocardial compliance and systolic dysfunction can cause presentation to be the symptoms of heart failure, such as breathlessness, rather than than with the chest imcover. Okay. Angioplasty and coronary artery bypass surgery provides symptomatic relief, although with an increased procedure, little morbidity and mortality. Outcome is determined by the number of disease vessels, severity of cardiac dysfunction, and number of concomitant disease as much as issue. Angioplasty and coronary artery bypass surgery provide symptomatic relief, although with an increased procedure, related morbidity and mortality. Outcome is determined by the number of disease vessels, severity of cardiac dysfunction, and number of concomitant disease as okay. But symptomatic relief, okay. Angioplasty and coronary artery bypass surgery, they only provide symptom relief, although with an increased procedure, related morbidity. There might be increased procedure, related morbidity and mortality. So this is dual eye situations in which eye patients should choose either they could die with a angina or they should die with an operation. Very difficult to make a decision. However, there are very cases that would help you to predict the death of the patient, and it was stratification of a stratification of myocardial infarction. It was called stratification of myocardial infarction. In those conditions, this it is used in those particular type of conditions. In case of old people, the stratification of acute coronary syndrome. This is called diagnosis and risk stratification. This is risk stratification. Okay, risk stratification. In this way, risk stratification in case of acute coronary syndrome. Okay, GRACE score. Okay, the GRACE score. This is called GRACE score. I was forgetting GRACE score previously. This is called GRACE score. I was just forgetting that. So let's get back to where we were. So let's get back to where we were. It is taking time. Okay, they are almost there. So we were studying angina in case of old people, and angioplasty and coronary bypass surgery is very risky in case of old people. That's all. ST segment elevation acute coronary syndrome. So reporting therapy in case of ST segment elevation acute coronary syndrome. Okay. Immediate reperfusion therapy restores coronary artery. Immediate reperfusion therapy restores the coronary artery. Artery's patency. Okay. If the procedure is done immediately, then it restores the coronary artery's patency, preserves left ventricular function, and improves the survival. So it should be done immediately. In this case, in this particular case, ST segment elevation case, survival. Successful therapy is associated with the pain relief. Okay, resolution of acute ST elevation. Okay, ST elevation will reach to the normal position, and sometimes transition arrhythmias. Okay, there might be a transition arrhythmias. So if the reperfusion therapy is successful, then the pain will be relieved, and ST segment elevation is normalized, and there is however there is a transient arrhythmia in some cases. Outcomes are best when it is used in combined with glycoprotein 2B3A receptor antagonist and antagonist stent implantation. In comparison with thrombolytic therapy, it is associated with a greater reduction in the risk of death, recurrent myocardial infarction or stroke. Okay, the universal use of primary percutaneous intervention has been limited by availability of necessary resources to provide the highly specialized emergency service. Thus, intravenous thrombolytic therapy remains the first line diffusion treatment in many hospitals, especially those in rural remote areas. Okay, when primary percutaneous intervention cannot be achieved within 2 hours of diagnosis, thrombolytic therapy should be administered. Thrombolytic therapy. So, what is thrombolytic therapy? Thrombolysis. The appropriate use of thrombolytic therapy can be can reduce hospital mortality by 25 to 50%. So when the thrombolytic therapy is given, when primary percutaneous intervention cannot be achieved within 2 hours of diagnosis. So it could not be achieved within the 2 hours of diagnosis. So in that particular time period, they should do the thrombolytic surgery. Thrombolytic surgery. Thrombolytic. They should do the thrombolytic surgery, and it reduces the hospital mortality up to 25 to 50%, and survival advantage is maintained for at least 10 years. That is too much. The benefit is greatest in those patients who receive treatment within the first hours, minutes, minutes mean muscle. Few hours mean muscle. I need to find this. Okay. Altiplase human tissue plasminogen activator or TPA is genetically engineered drug that is given over 90 minutes. Okay. Altiplase is a drug that is given over 90 minutes for the purpose of thrombolytic therapy. Thrombolytic means it's if there is any formation of thrombus in the coronary artery, then it lyses it. That which means it destroys the thrombus. So altiplase can be given. It is genetically engineered drug that is given over 90 minutes. For bolus dose 15 milligram followed by 0.7 milligram kg of body weight loss 30 minutes, then, but not exceeding 35 milligram. It use is associated with a better survival rates than other thrombolytic agents such as streptokines. Okay, streptokines could be given, but altiplase can be given. It is genetically injured streptokines. Altiplase could be given. So if the teacher in the class asks you should do streptokines, but altiplase is given, but carries slightly higher risk of intravenous intracervical bleeding. Analogs TPA is altiplase. Human tissue plasminogen activator. Human tissue plasminogen activator. Human tissue plasminogen activator. In short, it is called tissue plasminogen activator (TPA). And such as tenecteplase and retiplase RPA have a longer plasma half-life than altiplase. They have a longer plasma half-life and can be given in case of intravenous bolus. Tenecteplase and retiplase. TNK is effective as altiplase at reducing death and myocardial infarction, whilst conferring similar and intercerebral bleeding risk. However, the other bleeding and transfusion risks are lower. Other bleeding and transfusion risks are lower. And the practical advantage of bolus administration provide opportunity for prompt treatment in the emergency department or in pre-hospital setting. RPA, which is also known as retiplase, tenecteplase, and antiplase. Tenecteplase and antiplase has longer. Tenecteplase and antiplase have longer duration of action than the altiplase. However, the bleeding and transfusion risks are less common in case of altiplase, and the practical advantage of bolus administration provide opportunity for prompt treatment in the emergency department or in the pre-hospital setting. RPA is administered as a double bolus and also produces similar outcome to that achieved with altiplase. Although some of the bleeding risk appears slightly higher, an overview of all large randomized trials confirms that thrombolytic therapy reduces the short-term mortality in patients with myocardial infarction if given within 24 hours of the onset. If given 24 hours of onset. Okay. So primary PCI in case of ST segment elevation. elevation. Okay, primary PCI is more effective than thrombolysis for the treatment of acute myocardial infarction. Death, non-fatal reinfarction, and stroke are reduced from 14% of thrombolytic therapy to 8% with the primary PCI. Thrombolytic treatment in acute ST thrombolytic treatment in acute ST segment elevation myocardial infarction. So ST segment elevation myocardial infarction, ST segment elevation myocardial infarction, and ST segment non-ST segment elevation myocardial infarction. Both have different different management policies. Thrombolytic treatment in acute. Okay, prompt thrombolytic treatment within 2 hours and particularly within 6 hours of the onset of symptoms reduces mortality in person with the myocardial infarction and ECG changes ST segment elevation. And ECG changes of ST elevation or new bundle branch block intercranial hemorrhage is more common in people given thrombolysis with one additional stroke for every 250 people treated. Prompt thrombolytic treatment. Okay, prompt thrombolytic treatment within 20 to 12 hours and particularly within 6 hours of the onset of symptoms reduces mortality in patients with acute myocardial infarction. Electrocardiogram changes of ST elevation or new bundle branch block intracranial hemorrhage is more common in people given thrombolysis with one additional stroke for every 250 people treated. 250 people treated. Okay. Relative contraindication to thrombolytic therapy. Relative contraindication to thrombolytic therapy potential candidate for primary PCI. Primary PCI. Contraindication of thrombolytic therapy potential candidate. Okay. So who are the candidates who should undergo primary PCI? So patient with active internal bleedings. Okay. Previous subarachnoid or intercerebral hemorrhage, uncontrolled hypertension, recent surgery. So patient with bleeding disorders and recent surgeries, they just fall under the same categories. Recent trauma, it is also on the same category. High probability of active peptic ulcers, pregnancy, previous subarachnoid intercranial hemorrhage, uncontrolled hypertension. So I'm going to repeat this with my eye closed. Number one, there should be active internal bleeding, and then there should be recent surgery, recent trauma, and those who are with high probability of active peptic ulcer, uncontrolled hypertensions, and those with the intercerebral hemorrhage or subarachnoid hemorrhage, and pregnancies. Okay, pregnancy as well. Common arrhythmias in acute coronary syndrome. Common arrhythmias in acute coronary syndrome. Ventricular fibrillations, ventricular tachycardia, acceleration, interventricular rhythm, ventricular ectopics, atrial fibrillation, atrial tachycardia, sinus tachycardia, atrial ventricular block, ventral fibrillation. Common arrhythmias in acute coronary syndrome. Common arrhythmias in acute coronary syndrome. Ventricular fibrillations, atrial fibrillation, ventricular tachycardia. Okay. Ventricular fibrillation, ventricular tachycardia, accelerated interventricular rhythm, ventricular ectopics, fibrillation, tachysinus bradycardia, atrial block. Okay. Complication of acute coronary syndrome. Complication of acute coronary syndrome. Let's say acute coronary syndrome. What are the complications of acute coronary syndrome? Are seen all from the acute coronary syndromes, although the frequency and extent may vary with the severity of ischemia and infarction. Many major mechanical and structural complications are seen only significant, often transmitted. Okay. Only with significant, often transmittable myocardial infarction. Okay, often transmittable myocardial infarction. Arrhythmias. Many patients with acute coronary syndromes have some form of arrhythmias. In the majority of the cases, this is transition and of hemodynamic or prognostic importance. Pain relief, rest, and correction of hypokalemia help prevention of arrhythmias. Diagnosis and management of arrhythmias are discussed in detail on pyramid. Okay, ventricular fibrillations is also one of the complications of acute coronary syndromes. This occurs in 5 to 10% of patients. Okay, who reach hospital and thought to be major cause of death in those who die before receiving the medication attention. Prompt defibrillation restores sinus rhythm. Prompt defibrillation restores sinus rhythm and is life-saving. The prognosis of patients with early ventricular fibrillations within the first 48 hours who are successful and promptly resuscitated is identical to that of patients who do not suffer ventricular fibrillation. Now let's talk about atrial fibrillation. This is common but frequently transient and usually does not require emergency treatment. However, if it causes a rapid ventricular rate with a hypertension or circulatory collapse, prompt cardioversion by immediate synchronized DC shock is essential. DC shock is essential. DC shock is essential. This is common but frequently transient, okay, and usually does not require emergency treatment. It doesn't require any emergency treatment, and it is frequently transient. However, if it causes a rapid ventricular rate with hypertension or circulatory collapse, prompt. However, if it causes a rapid ventricular rate with hypertension or circulatory collapse, prompt cardioversion by immediate synchronized DC shock is essential. Prompt cardioversion by immediate synchronized DC shock is essential. In other situations, desoxy or beta blocker is usually the treatment of choice. Atrial fibrillation due to the acute atrial stress. Okay, due to the acute atrial stress. This does not usually require treatment, but if there is hypotension or hemodynamic deterioration, atropine may be given to treat the bradycardia. Atropine should be given to treat the bradycardia. AV block compliant impurity and infection is usually temporary and often results following reversion therapy. If there is clinical deterioration due to second degree or complete AV block, a temporary pacemaker should be considered. AV block complicating anterior infection is more serious because osteo may suddenly supervene. A prophylactic is temporary pacemaker should be inserted. So let's see. So what are the complications? There are three main complications we have studied right now. Number one is ventricular fibrillation, second is atrial fibrillation, and third is bradycardia. For the treatment of bradycardia, nothing is given. However, sometimes they could give atropine. In case of atrial fibrillation, the DC shock is essential. If there is DC shock is essential, and in case of ventricular fibrillation, just leave it. Ischemia. Are we on the new topic? Arrhythmia. No, yeah. This is the arrhythmias. Complex of coronary syndrome could be arrhythmia. Second, ischemia. Okay. Patient with develop acute angina at rest or minimal exertion following the acute coronary syndromes. Symptoms are at high risk and should be considered for prompt coronary angiography with a view of revascularization. Patient with a dynamic ECG changes and ongoing pain should be. How much is there for acute coronary syndrome? Damn it. Later in hospital means lifetime risk modifications. I will not study that. Mobilization. Secondary, okay. There. Too much. Okay, cardiac risk and cardiac non-cardiac surgery. Too much. Vascular disease. Now we are on the sixth topic. Still I have to study for almost 1 hour to finish this particular topic. Nope, no problem. Ischemia. Okay, ischemia. A person would develop recurrent angina or at rest or on minimal exertion following an acute coronary syndrome. At rest or on minimal exertion following an acute coronary syndrome are at high risk and should be considered for prompt coronary angiography with a view of revascularization. Patient with dynamic electrocardiogram changes and ongoing pain should be treated with intravenous. Okay, the patient who have dynamic ECG and ongoing pain should be treated with intravenous glycoprotein 2B3A receptor antagonist, and patient with a resistant pain or marked hemodynamic changes should be considered for intra-aortic balloon. Okay, the patient with resistant pain or marked hemodynamic changes should be considered with intra-aortic balloon countered pulsation and emergency coronary revascularization. Post-infarct angina occurs in up to 50%. Post-infarct angina occurs up to 50% of the patient treated with thrombolysis. Motivation have a residual stenosis in infiltrated vessels despite successful thrombolysis, and this may cause angina if there is still viable myocardium downstream. Okay, we need to study this sentence. Okay, post-infarct angina occurs up to 50% of the patient. Okay, post-infarct angina occurs up to the 50% of the patient treated with thrombolysis. Most patients have a residual stenosis most patients have a residual stenosis in infarct-related vessels despite successful thrombolysis, and they may cause angina if there is still viable myocardium downstream. Okay, for this reason, all the patients who have received successful thrombolysis should be considered for early coronary angiography with view of coronary neovascularization. Post-infarct angina occurs in up to 50% of the patients treated with thrombolysis. Most patients have residual post-infarct angina. The person who with the and after the anginas occurs post-infarct angina occurs up to 50% of patients treated with if they are treated with thrombolysis, there is still the person will still suffering from the anginas, and almost 50% of the person suffer from the angina after thrombolysis. Most patients have residual stenosis in the after the thrombolytic therapy, most patients have residual stenosis in the infarct-related vessels. So there is infarct in particular vessel and thrombolysis is done, there will still be the residual stenosis in that particular point. Despite so this will and that remaining will still cause angina if there is a still viable myocardium downstream. For this reason, all the patients who have received successful thrombolysis should be considered for early coronary angiography with a view of coronary neovascularization. Okay. Now, acute circulatory failure. Acute circulatory failure usually reflects extensive myocardial damage and indicates the bad prognosis. Although other complications of myocardial infarction are more likely to occur when the acute heart failure is present, the assessment and management of heart failure compiling acute myocardial infarction are discussed in detail in page number 5 and 1. Pericarditis, infection of a pericardium. This one of inflammation of a pericardium. This one occurs following the infection and is particularly common on the second and third days. The patient may recognize that a different plane has developed. This one occurs following the infection and is particularly common. The patient may recognize that a different plane has developed even though it is same and it is sometimes a pericardial lobe may be audible. Opiate-based analgesia should be used. Non-steroidal and steroidal anti-inflammatory drugs may increase the risk of aneurysm. Okay, and steroidal anti-inflammatory may increase the risk of aneurysm formation. The only cause of falling infection is particularly common on the second and third days. Okay, second and third days of a myocardial infection. There is a high chance of pericarditis. Patient may recognize that a different pain has developed. So before the second and third days, the patient would be experiencing different type of pain. But after the second and third day, they would experience a different pain. Even though it is at the same, but however the site is the site in that particular case is same, because what is at the same place, the pericardium is pericardium is basically covering a heart, so the pain would be on the same region because it is outside the heart, basically in the same site, and it is potential and tends to worsen or sometimes only be present on inspiration, and that it is positional, which means with the change in position the pain might reduce or it might increase with any particular position, and tend to be worsen or sometimes only present on inspiration. So it can worsen with the time, or it might be during the inspiration. Or pericardial lobe may be audible. This is the sound. Opiate-based analgesia should be given. So for the treatment of pericarditis, opiate-based analgesia should be given. Non-steroidal NSAIDs and steroidal anti-inflammatory drugs may increase the risk of aneurysm formation and myocardium rupture in the early recovery period, and should be avoided. The post-myocardial syndrome, Dressler syndrome, is very important. It's characterized by persistent fever. There's fever, pericarditis, and pleurisy. What is pleurisy? And it's probably due to autoimmunity. Now, I'm searching this term pleurisy. There's fever, there's pain, there's pleurisy. Isn't it the same word? Pleurisy. Pleurisy. What the hell happened? Just a minute. Just a minute. I think I just turned off the mic. Condition characters will see pictures of and sort with. So mechanical complications. Part of necrotic muscle is the first intract meteor to the rupture with devastating consequences. Rupture of papillary muscle can cause acute pulmonary edema and shock due to sudden onset of mitral regurgitations, which presents with pansystolic murmur and third heart sound in presence of severe regurgitation. The murmur may be quite or absent. Part of the necrotic muscle is the part of the necrotic muscle in the fresh intact mechanical. These were the complications, and this is the mechanical complication of okay, these are the mechanical complications. So subcutaneous pericarditis, okay, subcutaneous pericarditis ischemia is there. There is something called as arrhythmia. Then there is this ischemia, and there is pericarditis, acute circulatory failure. There is a reflex extensive myocardial damage and indicates a bad prognosis. All the complications of micro impacts and infractions are more likely to occur when the acute heart failure is present. The assessment and measurement of complications fairly complicating acute. Okay, so let's move on to the mechanical complications. Part of the necrotic muscle in fresh, in fact, may tear or rupture with devastating consequences. The necrotic muscle in a fresh, in fact, so in fact, in a fresh meter may tear or rupture with devastating consequences. Okay, so due to the micro infection, the muscles might tear or rupture due to the devastating consequences. Okay, rupture of the so what are the muscles that could rupture? Papillary muscle could rupture. Rupture of interventricular septum could rupture. Okay, so suppose this is heart and this is interventricular septum, and the papillary muscle are basically the muscle that connects the valve with the floor of the ventricles, and the septal region, interventricular septum, is a septum that separates right heart and left heart. So at first there is rupture of a papillary muscle that can cause acute rupture of papillary muscle that can cause acute pulmonary edema. When there is a rupture of this papillary muscle, there is acute pulmonary edema and shock due to sudden onset of several mitral regurgitations, which presents with a pansystolic murmur and third heart sound. Okay, pansystolic murmur. So in clinical examination, we can hear pansystolic murmur and we can hear third heart sound as well when there is papillary muscle damage that cause mitral regurgitations, which presents. Okay, so these papillary muscles are actually connecting this mitral valve. Are connected with the mitral valve. Whenever there is a loss of connection between papillary muscle and mitral valve, the mitral regurgitation occurs, leading to the pulmonary edema. How does the pulmonary edema occurs? There might be accumulation of blood in this area from this right ventricle to the lungs. Suppose this is lungs. There is this pulmonary artery that connects the heart from the heart to the lungs. Whenever there is there's accumulation of blood right here, the pulmonary edema occurs. So in this case, when there is a pulmonary when there is mitral regurgitation or papillary muscle damage, there is damage valve, and the damaged valve causes accumulation of blood all around here, even at all systole and diastole. So the accumulation of blood within this route might cause pulmonary edema. Yes. In the presence of severe regurgitation, the murmur may be quite absent. Okay, so pansystolic murmur and third heart sound is hot in case of clinical examination, but in case of severe regurgitation, the murmur may be absent, which makes it very more difficult and dangerous. The diagnosis is confirmed by echocardiography and emergency value. Okay, replacements may be necessary. Lesser degree of mitral regurgitation due to papillary muscle dysfunction or are common and may be transient. Okay, Rupture of intervertebral septum causes left to right slanting of the blood through the articular septal defect. This is the patient with sudden hemodynamic deterioration accompanied by new loud pansystolic murmur. Okay, so rupture of intervertebral septum causes left to right slanting of the blood, as I have told you, because it is the area which which separates the right organ. If there is damage intervertebral system, then blood will pass to this region, other side of the heart. This usually presents with a sudden hemodynamic deterioration accompanied by new loud pansystolic murmur radiating to the right sternal border. Radiating to the right sternal, but may be difficult to distinguish from acute mitral regurgitation. However, patients with an acquired ventricular septal defect tend to develop right heart failure rather than pulmonary edema. Getting this, I need to study this again. Mechanical complication. So it's not. Rupture of interventricular septum causes left to right slanting of the blood. Okay, ventricular septum. This is present with a sudden hemodynamic deterioration. There is hemodynamic deterioration accompanied by new loud pansystolic murmur. There is pansystolic murmur. Throughout the systole, there is hearing of the sound. New line. Okay, due to hemodynamic deterioration accompanied by new loud radiating to the right sternal border. So toward this is sternum, and here is heart. Then in the right sternal border, we can hear the pansystolic murmur. In case of ruptured interventricular septum, in case of a complication of acute coronary syndrome, relating to the right sternal border may be difficult to distinguish from acute mitral regurgitation. However, the patient with an acquired ventricular septal defect tend to develop right heart failure rather than pulmonary edema. Acquired ventricular septal defect tend to develop right heart failure than pulmonary edema. Doppler echocardiography and right heart catheterization will confirm the diagnosis. Right heart catheterization will confirm the diagnosis. Without the prompt surgery, the condition is usually fatal. Okay, rupture of ventricle. Rupture of ventricle. Okay, rupture of ventricle. There might be a rupture of ventricle. So this is what we've already talked about the papillary muscle. We'll already talk about this septal defect. Now ventricular rupture. This rupture of the ventricle may lead to cardiac tamponade and usually fatal. Might lead to the cardiac tamponade. It means cardiac tamponade basically means accumulation of blood within the pericardium and myocardium. Here, cardiac tamponade, and usually fatal. And although it may be rarely be possible to support the patient with an incomplete rupture until emergency surgery is performed. Embolism. Okay, embolism is other complications. Thrombus often form an endocardial surface of freshly infarcted myocardium. This can lead to a systemic embolism and occurs cause stroke or ischemia. Venous thrombosis and pulmonary embolism may occur but have become less common with the use of prophylactic anticoagulants and early mobilizations. Okay, impaired ventricular functions, remodeling and ventricular aneurysm. Impaired ventricular function, remodeling and ventricular aneurysm. Impaired ventricular function, remodeling and ventricular remodeling. Okay, impaired ventricular function. Ventricular function is impaired. Remodeling, I need to know this term. And ventricular aneurysm. Ventricular aneurysm. Okay, let's see. Acute transmural myocardial infarction is often followed by thinning and stretching of the infarcted segment. Okay, in case of acute transmural myocardial infarction, often followed by thinning and stretching of infarcted segment. Okay, there is thinning and stretching of the infarcted segment. In case of acute transmural myocardial infarction, there is thinning and stretching of the infarcted segment. It's also called infarct expansion. Okay, this leads to increase in wall stress with progressive dilation and hypertrophy of remaining ventricle. So this leads to the increase in so since there is thinning and stretching of the infarcted segment, there would be more stress in the wall of the ventricle. More stretching in the wall of the ventricle. Ventricles hypertrophy, the progressive dilation and hypertrophy. Sorry. There is stress. This leads to increase in wall stress. There is increase in wall stress, and there is dilation of ventricle as well as hypertrophy of the remaining ventricle. Okay, as the ventricle dilates, okay, it becomes less efficient and heart failure may supervene. Okay, it becomes less failure and heart failure can occur. In fact, expansion occurs over a few days. In fact, expansion occurs over a few days and weeks, but ventricular remodeling can take years. In fact, can expand over a few days and weeks, but ventricular remodeling. Okay, ventricular remodeling. Okay, remodeling is very broad term and it takes time for remodeling. However, there is a dilation of a ventricle and expansion of ventricle occurs within a few days. SC inhibitor therapy reduces the late ventricle remodeling and can prevent the onset of a heart failure. Angiotensin converting enzyme inhibitor therapy reduces the left ventricle remodeling lining and can prevent the onset of a heart failure. Okay, SCE. How does it do that? Reducing the blood load, I think. Workload of the heart will be decreased because much more amount of water is excreted to the urine in the absence of SCE inhibitors. So there would be less blood to pump and less stress on the wall and less dilations. Less stress on the wall will give the result to less dilation and less hypertrophy of the heart. Ultimately, ventricular remodeling. Okay. A left ventricular aneurysm develops in approximately 10% of the patient. Left ventricular aneurysm occurs in approximately 10% of the patient with myocardial infarction and is particularly common where there is persistent occlusion of infarcted vessels. Heart failure, okay. Ventricular arrhythmias, mural thrombosis, and systemic embolism are all recognized complications of aneurysm formation. Ventricular arrhythmias, mural thrombosis, and systemic embolism are recognized for other features include the paradoxical impulse on the chest wall, persistent ST elevation on the ECG, ST elevation on the ECG, and sometimes an unusual bulging of the cardiac. Echocardiogram is a diagnostic. The heart on the chest wall. It's great. Echocardiogram is a diagnostic surgical. Okay. Features of includes the paradoxical impulse on the chest wall, persistent ST elevation on the ECG, and sometimes an unusual bulging of cardiac shield in the chest wall. Actually, echocardiogram is a diagnostic surgical removal. Less infarct expansion and ventricular remodeling. Okay, increased chest wall and infarct expansion. Increased chest wall, infarct expansion. Okay, full thickness myocardial infarction causes thinning and stretching of the infarcted segment. Infarct expansion, which leads to increased wall stress with progressive dilation and hypertrophy of remaining ventricle, which is called as ventricular remodeling. And anything gets a high morbidity and mortality, but something necessary. Later in hospital management, okay. Late management of, okay, this is new topic. Later in hospital management. Late management of myocardial infarction is summarized in 18.71. Late management of myocardial infarction, risk stratification and further investigations. Late management of myocardial infarction, okay. Late management, okay, risk stratification of further investigations, lifestyle modification, okay, diet, cessation of smoking, regular exercise. Second, antiplatelet therapy, beta blocker, SC inhibitors, statins, additional therapy control diabetes, hypertension, manual cardiac risk antibodies, devices, implantable cardiac defibrillator, implanted cardiac defibrillator, implanted cardiac defibrillator. I need, okay. Cardiac defibrillators. What is cardiac defibrillator? Cardiac defibrillator. Okay, this is bad. Crap. Just leave it. Okay, where were we? Cardiac. Myocardial infarction in old age. I think I just studied this. Late ventricular ischemia. Okay. Risk stratification for the investigation. Simple clinical tools can be used to identify medium to high risk patients. The GRACE score, we have already studied this score, is a simple method of calculating early mortality that can help guide which patients should be selected for intensive therapy and specifically early patient coronary angiography. The prognosis of patients who have survived an acute coronary syndrome is related to the extent of residual myocardial ischemia, the degree of myocardial damage, and the presence of ventricular arrhythmias. I'm going to study this again. So simple clinical tools can be used to identify medium to high risk patient. The GRACE score is simple method for calculating early mortality that can help guide and patient should be selected for intensive therapy. So GRACE score basically helps if the patient should be on intensive therapy or specifically on the patient coronary angiography, or they should perform other treatments as coronary angiography. It generally gives the severity of the disease. It gives the severity of the disease, risk stratifications. The prognosis of patients who have survived an acute coronary syndrome is related to the extent of residual myocardial ischemia. Extent of residual myocardial ischemia, the degree of myocardial damage, and the presence of ventricular arrhythmias. These are the risk factors, basically. Left ventricular function, left ventricular function. The degree of left ventricular dysfunction can be crudely assessed from physical findings such as tachycardia, third heart sounds, crackles at the lungs bases, elevation venous pressure, and so on. Electrocardiogram changes and chest X-rays, size of the heart, and presence of pulmonary edema. Formal assessment with echocardiogram should however be undertaken in the early recovery phase. Ischemia. Patients with early ischemia following an acute coronary syndrome should undergo coronary angiography with a view of revascularization. Low risk patients. Ischemia. Patients with early ischemia, later in therapy, what should be? Patients with early ischemia following an acute coronary syndrome should undergo coronary angiography, okay, with a view of revascularization. Low risk patients without spontaneous ischemia should undergo an exercise tolerance test approximately 4 weeks after the acute coronary syndrome. Okay, 4 weeks after the acute coronary syndrome, they should undergo the exercise test. 4 weeks, okay. Exercise tolerance test, ETT, or exercise ECG. This will help to identify the individual with residual myocardial ischemia who require further investigation and may help them to boost the confidence of the remainder. If the exercise test is negative and the patient has good effort tolerance, the outlook is good with a 1 to 4% chance of adverse effect in next 12 months. In contrast, patient with residual ischemia in the form of chest pain or ECG change at low exercise. Okay, I'm not getting this. If the exercise, I'm just reading. If the exercise test is negative and the patient has a good effort tolerance, the outlook is good. Okay, outlook is good with a 1 to 4% of chance of an adverse even in the next 12 months. In contrast, patients with the residual ischemia in form of chest pain or ECG changes at low exercise levels are at high risk. So who are the high risk? The patient who have residual ischemia and chest pains along with some ECG changes are at high risk with a 50 to 25% of suffering of further ischemic events in next 12 months. So they have 15 to 25% of chances of suffering from ischemic event. Let's start this. So arrhythmias. What if the patient who have been treated with the myocardial? So these all are the later in hospital management. Okay, arrhythmia. The presence of ventricular arrhythmias during the convalescent phase of acute coronary syndromes may be a marker of poor ventricular functions and may herald the sudden death. Okay, may herald the sudden. Although empirical antiarrhythmic treatment is of no value and is even hazardous, selected patient may benefit from electrophysiological testing and specific antiarrhythmic therapy, including implantable cardiac defibrillators. Okay. Recurrent ventricular arrhythmias are sometimes manifestations of myocardial ischemia. Recurrent ventricular arrhythmias are sometimes manifestations of myocardial ischemia or impaired left ventricular function and may respond to appropriate treatment directed at the underlying problem. Recurrent ventricular arrhythmias are sometimes manifestations of myocardial ischemia. Recurrent ventricular arrhythmias are sometimes manifestations of myocardial ischemia or impaired left ventricular functions or impaired may refer to the concern and may respond to appropriate treatment directed at underlying problem. Lifestyle and risk factor modifications. Smoking. The 5-year mortality of patients who continue to smoke cigarettes is double that of those. 5-year mortality of the patient who continue to smoke cigarette is double that of those who quit smoking at the time of their acute coronary syndrome. The patient who continue to smoke cigarettes is double that of. Okay, the smoking is dangerous. Basically, giving out the smoking, the hyperlipidemia, lowering serum cholesterol falling. The importance of lowering serum cholesterol falling acute coronary syndrome has been demonstrated in large scale. Importance of lowering. So basically, the study has shown that lower the serum cholesterol, better it is. Lipids should be measured within 24 hours. So this is important thing. Lipids should be measured within 24 hours of presentation. Okay, because there is often transient fall in cholesterol in 3 months. There is often transient fall of cholesterol in 3 months following infections. SMG co-reductase enzymes inhibitors. Statins can produce marked reduction in total LDL cholesterol and reduce the subsequent risk of death, infection, strokes, and the need for revascularizations. Irrespective of serum cholesterol concentration, all patients should receive statin therapy after acute coronary syndrome, but those with serum LDL cholesterol concentration of irrespective of serum cholesterol concentration, all the patients should receive statin therapy. Okay, whatever the serum cholesterol may be, they all should be under the statin therapy. But those with the LDL cholesterol concentration above, but except the person who have 3.2 more than 3.2 benefit from 3.2 who have LDL cholesterol above 3.2 millimole per liter benefit from intensive therapy such as this will be given atorvastatin, more intensive. Atorvastatin is more invasive than statins. It should be given when the LDL is when the LDL in the patient is more than 3.2 mole per liter. So what are the risk factors? Other risk factors are maintaining an ideal body weight, eating a Mediterranean style diet, taking regular exercise, and achieving good control of hypertension, diabetes, mellitus are all important. This is okay. Mobilization and rehabilitation. The necrotized muscle of an acute myocardial infarct takes 4 to 6 weeks to be replaced with the fibrous tissue, and it is conventional to restrict the physical activities during the also for 4 to 5 weeks or about 1.5 months. Patients should not do exercises, heavy exercises, because the muscles, the infected muscles, are actually being replaced by the fibrous tissues within that period. During this period, when there are no complications, the patient can mobilize on the second day, return home in 3 to 5 days, and gradually increase activity with the aim of returning to work to 4 to 6 weeks. So they can walk on or going to their work within the 4 to 6 weeks. The majority of patient may resume driving after 4 to 6 weeks, although it must come to his vocational driving license holders. Heavy good and public service vehicles require special assessment. Okay. Emotional problems such as denial, anxiety, and depression are common and must be addressed. So after the myocardial infarction, the patient goes to home. Generally, the people who have suffered from myocardial infarction are older age people. So it is high chance that they could suffer from denial, anxiety, and depression, and therefore these should be addressed. Many patients are severely and even permanently incapacitated as a result of psychological effect. So psychological effects should be considered, because after a major surgery or major attack of myocardial infarction, this is a major disease. Patients have high chances that he or she could suffer from serious mental illness. Many patients mistakenly believe that stress was the cause of their heart attack. Okay, stress was the cause of their heart attack. May restrict their activity inappropriately. The patient's spouse or partner will also require emotional support, information, counseling, formal rehabilitation programs based on the graded exercise protocols with individuals, and group counseling are often successful and in some cases have been shown to improve the long-term outcome. Okay. Sorry. Okay, secondary prevention therapy after the disease. So patient comes to hospital, he gets treated, and he returns to home. And after that, the treatment is given. That treatment is called secondary prevention drug therapy. After that drug is given, so this is secondary prevention drug therapy. Aspirin and clopidogrel. Low-dose aspirin therapy reduces the risk of further infection and other vascular events by approximately 25% and should be continued indefinitely if there is no unwanted effect. Clopidogrel should be given in combination with aspirin for at least 3 months. If patients are intolerant of long-term aspirin, clopidogrel is a suitable alternative. Beta blockers. Continuous treatment with an oral beta blocker reduces the long-term mortality of approximately 25% among the survivors of the acute myocardial infarction. Unfortunately, a minority of patients do not tolerate beta blockers because of bradycardia, atrioventricular block, hypertension, or asthma. Patients with heart failure, uh, irreversible chronic obstructions, pulmonary disease, or peripheral vascular disease, they are similar, if not greater, secondary preventive benefit from beta blockers therapy. If they can tolerate it, so it should be tried. The secondary preventive role of beta blockers in patients with unstable angina is still unknown. Okay, SE inhibitors. Several clinical trials have shown the long-term treatments with an SE inhibitors. Several clinical trials have shown that long-term treatment with SE inhibitors. Several clinical trials have shown that long-term treatment with SE inhibitors, twice daily or ramipril 2.5 to 5.2 twice daily, can counteract ventricular remodeling. Okay, ventricular remodeling, counteract the ventricular remodeling. Okay, prevent the onset of heart failure. Okay, improve survival, reduce recurrent myocardial infarction, and avoid the rehospitalization. So AC inhibitors could be given. The benefits are greater in those with overt heart failure, clinical or radiological, but extend to patients with asymptomatic left ventricular dysfunction and those with preserved with left ventricular dysfunction. This should therefore be considered in all patients with acute coronary syndrome. Caution must be exercised in hypovolemic or hypotensive patients because the introduction of an AC inhibitor may exacerbate hypotension and impair coronary perfusion in patient intolerance of AC inhibitors and reservoir blockers. Valstatin, Prostatin, or clandestatin are alternative and are tolerated. Patient with acute myocardial infarction and left ventricular dysfunction. Patient with acute myocardial infarction and left ventricular dysfunction, ejection fraction less than 20, and either pulmonary edema and or diabetes for the benefit from additional medical glucose antagonism. Coronary revascularization. Most low-risk patients stabilized with revascularization. Most coronary revascularization. Most low-risk patients stabilized with aspirin, clopidogrel, anticoagulation, and anti-anginal therapy, and can be rapid immobilized in absence of recurrent symptoms. Low-risk patients do not benefit from routine coronary angiography. Coronary angiography should be considered with a view of revascularization in all the patients at moderate or high risk, including those who fail to settle on medical therapy, those with extensive ECG changes, those with elevated plasma troponin, and those with severe pre-existing stable angina. This often reveals the disease that is amenable to PCI or urgent CABG. In this case, coronary revascularization. Coronary revascularization is associated with short and long-term benefits, including reduction in myocardial infarction and death. Device therapy. Implanted cardiac defibrillators are of benefit in preventing sudden cardiac death in patients who have a severe left ventricular impairment. Prognosis. In almost 1/4 of the cases, myocardial infarction death occurs within few minutes without medical care. 1/4 of the cases, myocardial infarction death occurs within few minutes without medical care. Half of the death occurs within 24 hours of the onset of symptoms, and about 40% of all affected die within the first month. Okay, so the prognosis of those who survive to reach hospital is much better. The prognosis of those who survive to reach hospital is much better. Within 28 days of survival of more than 85% with the unstable, and then have mortality and approximately half that of person half with MI. Early death is usually due to arrhythmias and is independent of exact arrhythmias and independent of the extent of myocardial infarction. Independent of the extent of myocardial. However, late outcomes are determined by the extent of myocardial damage. So if the person who are dying within a few minutes, they are dying due to arrhythmias. However, the person who dies with in a 28 days, in a 28 days, they die due to the myocardial damage and unfavorable features, including poor left ventricular function. If we block persistent ventricular arrhythmias, okay, the prognosis worse of anterior than of interior. The prognosis worse of anterior than the inferior infarct. So inferior, in fact, is generally good than the anterior infarct. Myocardial infarction is in old age. I think I just studied this. I'll just give a study. Article penetration often with anorexia, fatigue, or weakness rather than the chest pain cause fatality rises steeply. Hospital mortality exceeds 25% in those over 75 years old, which is 5 times greater than that of seen in the less than 55 years. Survival benefit or treatments are not influenced by age. The absolute benefit of evidence of best treatment may therefore be greatest in older people. Hazards of treatment rise with the age, increased risk of cerebral bleeding and thrombolysis, and are due partly to increased comorbidity. Quality of evidence. Older patients, particularly those with significant comorbidity, were underrepresented in many of the randomized controlled clinical trials that help to establish the treatment of MI. The balance of risk and benefit for many treatments. Example, thrombolysis primary. Okay, I just thought I just keep a read. Give it a read. Cardiac risk of non-cardiac surgery. Cardiac risk or of non-cardiac surgery. Non-cardiac surgery, particularly major vascular abdominal or thoracic surgery, can precipitate serious perioperative cardiac complications such as there is surgery of other part of the body, but it can lead to the damage of a heart. How? We're going to study this. Non-cardiac surgery, particularly major vascular abdominal or thoracic surgery, can precipitate serious perioperative cardiac complications such as myocardial infarction and death in patient with coronary artery and form of heart disease. Careful perioperative and cardiac assessment may help to determine the balance of benefit versus risks of an individual basis and identify measures that minimize the operative risk. The hypercoagulable state is part of the normal physiological response to surgery and may promote coronary thrombosis, leading to an acute coronary syndrome in the early post-operative period. Patients with a history of recent percutaneous intervention or acute coronary syndromes are at greater risk. When possible, elective non-cardiac surgery should be avoided for 3 months after such an event. Antiplatelet agents, statins, and beta blockers reduce the risk of perioperative myocardial infarction in patients with coronary artery disease, and where possible, should be precipitated throughout the perioperative period. Careful attention to fluid imbalance during and after surgery is particularly important in patients with impaired left ventricular function. Careful attention to fluid balance during and after surgery is particularly important in patients with impaired left ventricular function and valvular damage. This is because antidiuretic hormone is released as a part of the normal physiological response to surgery, and in the circumstances, the overzealous administration of the intravenous fluid can easily precipitate heart failure. Patients with severe valvular heart disease, particularly aortic stenosis and mitral stenosis, are also at increased risk because they may not be able to increase their cardiac output in response to stress of surgery. Atrial fibrillation may be triggered by hypoxemia, myocardial ischemia, or heart failure, and is a common post-operative complication in patients with pre-existing heart disease. It usually terminates spontaneously when the precipitating factors have been eliminated, but digoxin and beta blockers can be prescribed to control the heart rate. So this was all in this video.